while I do these things. All right. We're going to talk about cultural assessment for healthcare providers, because diversity is more than just, if you're French, you do this. If you're German, you do this. So we know that the United States is a very diverse nation made up of very many different cultures, and that culture influences a person's perspectives, their values, and their behaviors about health and well-being as well. So it's really important that we understand this stuff. This is how we used to think about cultural diversity, right? It's impolite to open gifts when received. If you're French, you do this. If you're Korean, you do this. But it's really a lot more than that now. Let me turn my camera off. There we go. All right. So a couple things we're going to do. One, we're going to define the terms: cultural diversity, cultural competency, and implicit bias. We're going to start to understand some of the subtopics within those terms and the role of implicit bias in culturally competent care. We're also going to understand why cultural differences are important in healthcare, give some strategies for giving good culturally competent care, and identify the risks and the impact of implicit bias with our within healthcare and with our patients as well. All right. So we'll start with the cultural diversity, cultural competency. So diversity is the variety of customs, attitudes, behaviors, practices that exist among groups of people from different ethnic, racial, or national backgrounds who come into contact. Cultural competency is that strategy to reduce the disparities in accessing healthcare through understanding the cultures, as well as the social, economic, and ethnic influences on an individual's health beliefs and behaviors. Just like with patient engagement and patient activation, you got the big topic, and then you've got the more individual topic. All right. This is one of my favorite quotes. Obtaining cultural competency is an ongoing, lifelong process. It is not an endpoint. You don't take a class and go, oh, I'm culturally competent. Nope. It continues for the entirety of your life and your practice. Why is this so important? We need to understand what the issues are that we're facing in healthcare when it comes to creating and fostering an inclusive environment where everybody from any cultural background, race, ethnicity, gender, religion, sexual orientation, or more, feel welcome and feel valued, and more importantly as well, feel safe to come and get care. We need to make sure that there's equity, that our individuals have access to all the same opportunities and the resources, the benefits, regardless of their background or how they identify. Excuse me. And the reason that we do cultural diversity training is to develop those cultural competence skills among individuals and organizations. Being culturally competent means that you have the knowledge base, the skill set, and the attitudes to interact with people effectively and respectfully across their diverse backgrounds. It requires you to be aware of your own cultural biases and to adapt your behavior and your communication styles when interacting with others from different cultures. All right. The concept of diversity encompasses acceptance and respect. Everybody is a unique person, and we need to recognize our individual differences. I like word clouds. But look, that's a cultural competence word cloud. All right, so some components of culturally competent care: cultural awareness, self-examination of your own cultural and professional background, gives you some insight into somebody else's beliefs. So what's important to you may not be important to somebody else, but if this topic is important to you, there may be importance in other people's culture, but it might not be the same approach. Cultural knowledge, seeking and obtaining that information based on different cultural and ethnic groups. Cultural skill is the ability to collect relevant cultural data regarding the patient's presenting problem and accurately perform a culturally specific assessment. I'll get into a couple of different assessment tools a little later on. Then your cultural encounter is that process that encourages us to directly engage in cross-cultural interactions with patients from culturally diverse backgrounds. And then desire refers to the motivation to become culturally aware and to seek those cultural encounters. Be open to others, to accept and respect those differences, and be willing to learn from others. So, a little bit of a self-assessment, things to think about. What does being culturally competent mean to me and the patients I serve? What cultural competency tool or model is most useful to me given the population that I work with? How can I use the information that I gain to improve my patient's outcome and reduce disparities? So, how many of you are aware that there are cultural competency tools and models that are available for you to use to do good culturally competent assessments? You put that in the chat or the Q&A. If you know of tools or you don't know of tools, put yes or no. Excuse me. All right, moving on. So we use these types of things all the time, right? You look at it and you say, okay, how do I get started on this journey? How do I learn about cultural competence? And you have to really decide where you're at on this continuum. Are you willing or unwilling? Are you able or unable? So if you're willing and able, you are in that top right quadrant where you've got the aspiration and you are involved and engaged. If you are willing or if you are unwilling but able, you're maybe there's some uncertainty or some fear there. Maybe you need to do a little bit of work to figure out why you're not willing to explore this area. If you are unwilling and unable on the bottom left, you're not prepared for change. You may be in denial. There may be some lack of understanding, a lack of opportunity, or a fear of acting incorrectly. So rather than make an error, you're just not going to do it at all. And if you're willing but unable, you're developing that eagerness to learn. Maybe you know some stuff already, but you have very low expectations and you're just basically giving cultural competence lip service. So where are you on this continuum? Why is it important? Well, we need this to reduce health disparities, to increase health equity, to dispel stereotypes, and again, promote patient and family-centered care. Children from poor families are over 28% more likely to experience poor communication with their healthcare providers. Hispanics have a higher rate of AIDS, more than 3.5% higher, 3.5 times higher than any other ethnic group. African American children have a higher risk of hospitalization from asthma. Asian adults are 50% more likely to lack immunization against pneumonia. And lower socioeconomic groups have higher mortality rates from cancer. Can we agree that we need to reduce disparity and improve health equity? All right. Excuse me. Some major categories that we look at are denoted here. We'll start at the top on the right. Sexual orientation, religion, socioeconomic status, gender, age, race, ethnicity, culture, and disability. This is a far cry from the if you're Korean, you do this. If you're French, you do this. This really takes into consideration the person as a whole, because cultural competence doesn't just include your race and ethnicity. It takes in everything about your personal experience. It's your personal culture, if you think about it. So some subcategories within those major categories, within many religions, there are different sects. So maybe you're, I'll use mine. Maybe you are a Christian, but what sect do you belong to? Are you Lutheran? Are you Catholic? Are you there's a whole bunch of them, right? Age. What generation do you belong to? Janet Coulter did a really, really great presentation at National last year about the different generations and how we can be generationally competent. Socioeconomic, what socioeconomic factors influence their culture? Race, what's their ethnicity, their language, their region? Within every race, there are different regions, there are different languages, there are different dialects. Disability, physical or mental disabilities. You've got gender. LGBTQIA+. How do people identify there? Sexuality, heterosexual, member of the LGBTQ community. So remember, no one individual is defined by a single category. So looking at this pyramid, how do you define yourself? Because starting with you is probably the best way to understand this. So if we start at the bottom, we're building a base, right? Just like with a pyramid. Cultural, your power distance, how far, it's personal space. And when people get up on you really, really close, do you get like, get away from me? Or you keep people at an arm's length? When you're making decisions, is it the decision of a single person versus a collective? Identifying as feminine, masculine, or neither. Uncertainty, avoidance, how do you manage stress and crisis? And then are we looking more at a short-term or long-term orientation? Then you get up to the next level, demographics. This is where the basic stuff really comes in: age, gender, sex, ethnicity, geographic origin, et cetera, et cetera, et cetera. And then we get to the individual part at the top of the pyramid. What are your own personal beliefs and values, your motives and attitudes? What's your knowledge base look like? What are your expectations? And how about your needs? So if you look at this pyramid and you start sketching out you, what do you look like? And then realize that that is you and that everybody else has a very, very different look at on all of these things. And not one person is the same as the other. So let's put it all together. And we're going to do it with some healthcare considerations too. And we have lots of different things that we have to consider with culture. Decision making, who's making the decisions? Is it being made by a single person? Is it being made by a group of people? Is the patient or the family deferring to somebody that is identified as the decision maker or the leader due to cultural issues or cultural beliefs? End of life care. We've all seen presentations about cultural consideration and end of life care and how that can differ from culture to culture to culture. So we have to understand what that looks like. The same thing with obstetrics care. There are cultures where men are not allowed in obstetrics care because that is a female thing. So we have to understand if you've got, somebody coming in for obstetrics care and there's a male provider present, they may be asked to leave. And then medical treatment, you look at cultural practices, with, I've seen presentations before, with the hot and the cold, the yin and the yang and things like that. And you have to take those into consideration. But really that has a huge impact on how a patient is either going to consent or not consent for treatment. When you look at Jehovah's Witnesses, we have a large population of Jehovah's Witnesses at the hospital that I work at as patients. And we know from the get-go that they're staunchly opposed to receiving blood products. And so we have come up with a workflow and a solution for making sure that these patients can be taken care of in a culturally competent way that does not include even the conversation of blood products unless they broach it first. All right. So all that being said, and people are different, and everybody's different. What's the impact of implicit bias? So first, let's know what implicit bias is. The word bias is very charged. The concept of implicit bias, I don't think is very well understood. But keep in mind that this is an automatic and unconscious thing that goes on in your brain. This is actually how your brain is wired by genetics and by function, because if we had to take in and process and make decisions on every piece of information coming into our brain, we would never be able to get anything done. And we would just be locked in this, I can't do anything. So your brain actually works off of previous experiences, takes in all this stuff, and starts making shortcuts in your head. And these are called implicit biases. They're also called stereotypes that you may hold for certain groups of people based on characteristics such as race, gender, age, ethnicity. They are formed through your societal influences, maybe your personal experiences, and they affect your perceptions, your judgments, and your behaviors without even being conscious of doing this. So imagine you're in a job interview and you subconsciously assume that the candidate who shares your alma mater or your hobbies is a better fit for the role, even though these factors are completely irrelevant to the job performance. This is an assumption of an example of implicit bias because it's based on unconscious associations rather than objective qualifications. The unconscious nature of implicit bias means that these things can influence your thoughts and actions without you intentionally choosing or activating them. Again, they operate in the background of our minds. So therefore, it's very essential for us as peoples to recognize and address them through self-awareness and diversity training. Everybody has them. This is, again, biological, your brain's tendency to make generalizations. This is an unconscious mental process that helps us deal with the millions of pieces of input that we experience every day. These are brain shortcuts. This is nothing to be stigmatized for or ashamed of, but the key to this is knowing what your implicit biases are and doing the work to rewire your brain. Okay, so they don't impact your ability to function in society, to care for your patients holistically, equitably, and in an unbiased nature. All right, so again, your unconscious, implicit biases, effortless, automatic, and fast. These are things that just live in your head, and so you don't have to deal with it. Your brain goes poof, right to the shortcut. Explicit biases, these are a conscious decision. These are effortful, they take some time, they're very deliberative, and they are slow moving. All right, implicit biases impact on decision-making in the healthcare. It are often, again, intentional and counter to the goals of diversity and inclusion. So these shape how we perceive others. They're snap judgments based on your stereotypes that could affect your initial impressions and your interactions. If you hold an implicit bias against a particular racial group, you may unconsciously perceive all members of that group as less competent or trustworthy. Implicit biases can also manifest as microaggressions, which are subtle, often unintentional discriminatory actions or comments. These microaggressions can also create a hostile or unwelcoming environment for marginalized individuals. It can erode morale or trust within a team or an organization, or the trust of the patient in the healthcare organization. And implicit bias can also affect our communication patterns because we may unknowingly change our communication styles based on stereotypes. This could exclude people, causing some people to feel marginalized or unheard in discussions or decision-making processes. Unconscious influence, because it operates at a subconscious level, we may not be aware of these, and these biases can influence our perceptions, our decisions, and our behaviors. Without addressing these, we may appear to be inconsistent. We might consciously support diversity and inclusion in theory, but act in ways that undermine the principles. So that creates mistrust, confusion, and mixed messages. Decision-making processes such as hiring, promotions, and team assignments, when left unaddressed, implicit biases can lead to unfair or biased outcomes, which are contrary to our objectives. It reduces our inclusivity, I can't say that word, inclusivity, hindering the development of inclusive environments, hindering the ability for all people to feel valued and respected, cutting down on collaboration and teamwork, and you're not utilizing the full diverse talents and perspectives of the team to their fullest. And also, let's take a look at some legal and ethical concerns. Failing to address implicit biases can expose organizations to legal risk, damage their reputation. Yikes, don't want that. Significant impact on patient interactions, leading to disparities in care and outcomes. Refers to those unconscious attitudes, those stereotypes, those judgments that healthcare providers may hold about patients based on things that have absolutely nothing to do with healthcare: race, ethnicity, gender, age, socioeconomic status, and other factors. So it could also impact how healthcare providers diagnose and treat patients. Research has shown that racial and ethnic minorities may receive less aggressive pain management, fewer cardiac interventions, and less thorough diagnostic testing than their white counterparts, resulting in delayed or inadequate care for minority patients. Communication is impacted. We may use different communication styles or provide less information to patients that we perceive as different from ourselves. This can lead to misunderstandings, reduced patient engagement, and decreased adherence to treatment plans. Oh, they won't understand this. We're not going to bother. Patients who perceive bias from healthcare providers are less likely to trust their recommendations or engage in their own care. So that can hinder that patient-provider relationship, and that leads to bad outcomes. Implicit bias contributes to health disparities, perpetuating unequal treatment and outcomes, worsening health outcomes, higher morbidity, higher mortality rates for marginalized populations. I saw this when I was doing research for the readmissions book. There's a couple of studies that show safety net hospitals were being unfairly penalized for readmissions at a higher rate because of the lack of engagement and patient activation. And that had to do a lot with the disparities at safety net hospitals in providing good education to the patients and follow-up. And so there was a lot of impact from health disparities and implicit bias on readmissions for marginalized populations. Patients who experience bias from healthcare providers suffer from stress and psychological distress. What's worse than going to your provider and they treat you poorly because of their own implicit biases that they don't even realize that they're doing? But how do you have those conversations with your provider? Hey, you know what? I feel like you're doing this, this, and this, and then you have that reaction from the other person going, "Oh no, that's not me." Well, consciously, that's not you, but subconsciously, that may be what they're experiencing from you. And so we have to validate what a person is feeling and do the work to identify that within ourselves. Access to care. If a healthcare provider holds biases against certain groups, they may be less likely to refer patients for necessary care or provide inadequate support when the patient is seeking medical attention. And then cultural competence. Providers who are unaware of or dismiss cultural nuances may not fully understand a patient's health beliefs, their values, or their preferences. That can lead to either misdiagnosis or creation of inappropriate treatment plans, and again, non-adherence because they're not working with the patient about what works for them and what doesn't. So how do you mitigate the impact of implicit bias? If this is going on in our heads automatically, and it's based on shortcuts that your brain is making up as they go, how do you fix that? Well, you should undergo regular training to understand what implicit bias is and its consequences. Increased diversity among healthcare providers helps reduce that bias and improve cultural competence because you're being exposed to more different types of people, more different types of cultural influences, which then helps your brain kind of reroute itself. Clinical guidelines. Implementation of evidence-based clinical guidelines helps standardize care and reduce the influence of bias on treatment decisions. Everybody gets the same care everywhere. Patient-centered care, making sure that patient-centered care and shared decision-making is implemented so that patient has the power to be involved in the decision-making. That can help to reduce the bias, the impact of bias. And data collection, understanding what your patient outcomes look like across demographic groups so that you can use that data to identify and address disparities. And again, getting that feedback from your patients and colleagues helps us be more aware of our biases. And this is much more than Press Ganey scores that come out at a percentile. You want those words coming from your patients and your colleagues. You need to see the narrative. All right, so how do we perform a culturally competent assessment? Well, there's several different tools, and y'all know I love doing research and I love looking at different tools and techniques. So I found a few different models out there for doing culturally competent assessments. Culturally competent, the process of cultural competent delivery in healthcare. This is called the ASKED format, ASKED. Then there's the Purnell model of cultural competence. the Geiger and Davidsar transcultural assessment model, and then Spector's health transitions model as well. So you got 4 different choices that we're going to kind of go over real quick. So the asked assessment is on your left-hand side. Awareness, skill, knowledge, encounters, and desire. Very, very basic. You're just looking at, okay, what's my awareness? What's my skill here? What's my knowledge about this culture? What kind of encounters have I had? And what's my desire to learn more? Purnell's wheel, we're going to get into a little bit more. That's the one that I showed a little earlier. It's one of my preferred ones. What's your culture? Use each section to identify yourself. Which areas are your strongest identity in and which are less important? Because not all of these are equally important. If you would ask me what my culture is, and you see on the outside of that wheel, you've got education, work experience, appearance, family, political belief, just on that top part of that outside wheel. Work experience, I love my work. My work is my life, right? Education is very important to me. My family is probably first and foremost in my world. Political belief ranks lowest across that top section. And just above political belief is appearance, because if you see me on the weekends, my hair's in a ponytail, I'm wearing jeans and a t-shirt, and I don't care. So again, just as an example, you can see that not everything is going to be at an equal, oh, this is important level. So what areas are strongest in your identity and what's less important to you? Okay. And that's for everybody. So we're going to do a little bit of a case study using that wheel for a holistic assessment. We have Amina Idris. She's a 38-year-old Somali woman, Muslim, recently migrated to the United States. Rachel Adams, case manager, experienced but new to working with Somali patients. And Dr. Kevin Harris, who is Amina's primary care physician. So she visits the community health center with her 3 children. She's recently migrated to the United States, has limited English proficiency, presenting with symptoms indicative of chronic stress and possible depression. Rachel, her case manager, decides to use Purnell's model for a comprehensive cultural assessment to help guide Amina's care plan. So overall heritage, she comes from a collectivist society in Somalia with strong family bonds and Islamic religious practices. She prefers to communicate in Somali and values indirect communication styles. She is not comfortable with direct eye contact from male healthcare providers. Very important. Family roles. Amina is from an extended family structure where elders are highly respected. Decision-making is usually a family affair. She has never been employed outside the home and has limited understanding of the healthcare system in the United States. She has dark skin, which may affect dermatological assessments. There's no known specific genetic predispositions. She limited due to high-risk behaviors, limited due to religious and cultural beliefs. She avoids alcohol and pork. Nutrition, halal dietary practices are essential. She is accustomed to a diet rich in vegetables, grains, and meats, but finds it challenging to maintain this in the United States. Pregnancy and childbearing practices. She has specific cultural beliefs about childbirth, postpartum care influenced by Islamic teachings. Death rituals. The Islamic beliefs strongly influence Amina's views on death and dying, emphasizing dignity and family involvement. She is a practicing Muslim. Her faith plays a significant role in her life and health decisions. She uses traditional remedies and prefers female healthcare providers. She's hesitant about mental health services due to cultural stigma. And her trust in healthcare practitioners is influenced by her experiences with the healthcare system in Somalia and refugee camps. So you can see how going into Purnell's wheel, you're getting a really, you've got a picture of Amina around, right? What are our interventions for her? Rachel's going to collaborate with a culturally competent interpreter and includes Amina's dietary preferences, religious practices, and family structure in the care plan. With the mental health sensitivity, she arranges for Amina to see a female mental health specialist experienced in working with Somali refugees and connects Amina with the local Somali community groups for social support and better integration. The outcome, Amina feels respected, heard, and understood, leading to greater trust building with that healthcare team. She becomes more engaged in her healthcare, improving her adherence with the plan, and Rachel's use of Purnell's model enhances her understanding and effectiveness in managing culturally diverse patients, especially with the Somali cultural group. So that's Purnell. Geiger and Davidsar's transcultural assessment model is You got the culturally unique individual and all these areas feeding into it and out of that person. And then you've got the nursing assessment that gets done at the time of admission. All right. So communication emphasizes the importance of language and communication styles, including verbal and nonverbal. You must be aware of your patient's preferred language, tone, gestures, and eye contact preferences, space, physical distance that should be maintained during interactions. Keep in mind that this can vary culturally. So making sure that you understand a person's space preferences is very, very important. Social organization, understand the family roles, the hierarchy, and the importance of community. Time, perceptions of time can be different across cultures. Some cultures are more present oriented, or more others may focus more on future or past, and you have to understand that to work with your treatment plans. Environmental control includes the person's perceived ability to control their environment and their destiny, including health outcomes. So look at it, cultural beliefs about luck, fate, self-efficacy can greatly influence this. So, some people look at it, I got this disease as a punishment, or this is just my fate. I don't have any control over it. Or, just the luck of the draw. The final aspect of biological variations, different ethnic and racial groups have varying biological responses to medications, nutritional preferences, and susceptibility to certain diseases. We know this. So making sure that you take that into consideration as well. So for case managers, integrating Geiger and Davidsar can be pivotal, not only enhancing the quality of care, but also making sure that the care delivery is respectful and responsive to, of course, the individual needs of the patient population and the patient itself. So we're going to do a really quick Geiger and Davidsar. So you've got Daniel Kim, a 50-year-old Korean-American man, recently diagnosed with diabetes. Laura Benson is the case manager, experienced in diabetes, but again, new to working with the Korean-American population. And Dr. Anita Patel is the endocrinologist. So Daniel Kim is referred to the urban hospital after being diagnosed with type 2 diabetes. Laura aims to use Geiger and Davidsar's transcultural assessment model to develop a culturally sensitive care plan that addresses Daniel's unique needs. All right. Daniel speaks fluent English, but prefers to communicate in Korean when discussing complex health issues. He values a respectful and formal communication style. With space, Daniel is very comfortable with close personal space in social settings, but prefers more physical space during medical examinations. Social organization, he places a high importance on family and expects them to be involved in his healthcare decisions. He respects elder family members and looks to them for advice. Time, he has a present-oriented time perspective, focusing on immediate issues rather than long-term implications. So sitting there telling him all about how, in 10 years, this could lead to this isn't going to have much of an impact on him. He wants to know what's going on now. Environmental control, he believes in a balance between personal control over his health and fate. He is open to medical advice, but also values traditional Korean remedies. Biological variations, he has lactose intolerance, which is common in many Asian populations, and his dietary needs must be considered in diabetes management. Interventions, well, Laura arranges for a Korean-speaking healthcare professional to assist in complex discussions with Daniel. Recognizing the importance of family in his decision-making, she involves the family, with his permission, in care planning sessions. Works with the dietitian to develop a diabetes-friendly diet plan that accommodates traditional Korean foods and lactose intolerance, and provides educational materials on diabetes management in both Korean and English, ensuring that he understands his condition and treatment. The outcome, again, Daniel feels respected, he feels heard, he feels understood, and he's more trusting of the healthcare team. He has gotten a better chance of actively participating in his care plan and improving his diabetes management. And Laura is benefiting as well because she's able to provide culturally sensitive care to Daniel, and she's learned a little bit more about managing that population as well. So we just talked about communication, space, biological variations, the environmental control, what's their time frame, what time perspective are they looking at, and their social orientation. Need to identify their preferred language, be aware of tone, of pronunciation, use of body language and silence. With space, what's your patient's comfort level regarding proximity of others? With Daniel, we saw that he was okay with, having social conversations closely, but when he was in the medical examination, he preferred a more formal space because, that's a more formal thing for him. Biological variation, what makes these people, this group or this population unique with their physical attributes, with their genetic history and their predisposition for diseases? What about their nutritional preferences or deficiencies and their psychological characteristics? We saw with Amina that there's a stigma attached to mental health. We saw with Amina that she had very dark skin that would impact a dermatology assessment. So the dermatologists would need to take that into consideration. Environmental control. What about cultural beliefs about health and illness? There's many different cultural beliefs out there about health and illness. Making sure that you explore those with your patients is very important. And again, what's the patient's time orientation? Are they looking long-term, or like Daniel, did they only want to talk about what's going on right now? And, don't tell them about the 10-year impact of diabetes. Tell them what he could do about it right now. And then what is the patient's culture, race, or ethnicity and their family role? What part does work play in their life? Does church or religion and friends, their social life and their social environment? All right. Consider the patient's background and culture when you're completing assessments. Speak in their preferred language, or again, soapbox, medical interpreter services. Develop treatment plans with the patient's culture based on health beliefs included, recognizing the significant impact that those beliefs play in outcomes, and understand your own implicit biases and the impact that they may have on your interactions. So I'm going to do patient X, patient Y, and patient Z. So is this enough information for you? Patient X is male, African-American, 18 years old with the diagnosis of sepsis and fever. Patient Y is female, Mexican-American, 40 years old, diagnosis pancreatitis. Patient Z, male, Palestinian-American, 75 years old with a diagnosis of CAD. Is this enough for anybody to work on, much less a case manager? Yet this seems to be what we get sometimes, right? All right. A mid-sized hospital in a diverse urban area has been experiencing challenges related to cultural diversity among its patients. The case management team, although skilled and experienced, predominantly comes from a similar cultural background, which is different from many of the patients that they serve. Maria Rodriguez, a 50-year-old Latina woman, is admitted to the hospital for complications related to diabetes. She's assigned to John Smith, who is an experienced case manager. John is not fluent in Spanish, encounters communication barriers with Maria, who primarily speaks Spanish. He relies heavily on medical interpreters, but struggles to fully understand Maria's cultural perspective on healthcare and her personal beliefs. During their interaction, John unconsciously makes assumptions about Maria's understanding of her medical condition and her compliance with medical advice based on his previous experience with other Latino patients. This implicit bias affects his communication with Maria, leading to a lack of trust and feeling disconnected on her part. Now, remember, implicit biases are based on your previous experiences, and they're shortcuts that your brain takes. So, I mean, it's not being mean to John to say, he's doing this purposefully, but it's based on his previous experiences with other Latino patients. So therefore, he is making assumptions based on that, which he should not be doing. John's implicit biases and the cultural disconnect lead Maria to feeling misunderstood and not supported. She becomes less engaged in her treatment plan. Of course, this adversely affects her health outcomes. And the case management team realizes that they need to address these cultural and communication challenges in order to provide effective and personalized care for Maria. All right, so what's our solution? Well, 1, cultural competence training. Extensive training for the case management team, actually for the entire hospital, on cultural competence, understanding implicit bias, and how to mitigate its impact. Enhance communication tools with the introduction of multilingual resources and tools to help the case managers communicate effectively with patients from diverse backgrounds. A patient-centered care approach to understand the patient's cultural background, personal beliefs, individual health practices, implementing one of those assessment tools. Regular feedback, so setting up a feedback system for patients. And again, that narrative is important. And then also creating practice sessions for case managers to understand and learn from those insights. Maybe a patient advisory board related to cultural competence. So after implementation of those strategies, the team reports an increased appreciation and understanding of cultural diversity. John is now able to rebuild his relationship with Maria. Maria feels more respected, more heard. She becomes more involved in her care plan and is more adherent with her treatment plan and therefore has better outcomes. All right. By embracing this cultural competence and patient-centered care, we can significantly improve our patient engagement and our health outcomes. Next one up. We've got James Robinson, a 45-year-old African-American male presenting with hypertension and a history of type 2 diabetes. Dr. Emily Thompson is a primary care physician. She's relatively new to the community and its demographic diversity. Lisa Nguyen, case manager, experienced in urban health settings, but not specifically trained in cultural competency. And Nurse Jackson, an African-American nurse who's been in clinic for 15 years, familiar with the community's cultural dynamics. So Mr. Robinson is an African-American male who visits the community health clinic for routine checkups. He's diagnosed with poorly controlled hypertension, has a history of type 2 diabetes. Dr. Thompson notices his non-compliance, we call it non-adherence, with previous medication and lifestyle recommendations. And Lisa Nguyen is tasked with developing a comprehensive care plan for him. During the consultation, Lisa observes several interactions. One, Dr. Thompson appears frustrated with James' non-adherence and attributes it to a lack of responsibility, overlooking any potential underlying factors. James seems reluctant to discuss his lifestyle and medication adherence, appearing defensive when questioned. Nurse Jackson, who has a rapport with James, later informs Lisa that many African-American patients in the community have a deep-seated mistrust of the healthcare system, often rooted in historical and personal experiences. So where are we at with the implicit biases? Well, let's take a look at Dr. Thompson. She assumes that James' noncompliance is due to personal irresponsibility and not considering any of the sociocultural factors that Nurse Jackson knows about. Lisa's initial approach overlooks the impact of James' cultural background and experiences with the healthcare system. And James' reluctance to fully engage in his care plan is influenced by a broader context of healthcare mistrust among African Americans. So what do we do about this? Well, cultural sensitivity training. Lisa can organize a clinic-wide training on cultural sensitivity, focusing on the specific needs of that community, the African Americans community's healthcare perspectives. By building trust, Lisa and Nurse Jackson can collaborate to create that more culturally sensitive care plan, given that Nurse Jackson understands the implications and is willing to educate everybody about them, incorporating his cultural preferences and addressing his concerns. And then Lisa, with the community, can facilitate outreach programs to help build trust and improve healthcare engagement among the African American patient population. Outcome, James feels more understood and respected. He's going to be more adherent with his care plan. Dr. Thompson is gaining a deeper understanding of the cultural factors and implicit biases that she holds in her patient care and is working to mitigate those. Lisa's approach to case management evolves, emphasizing cultural sensitivity and patient-centered care, which also leads to better outcomes for patients for more diverse backgrounds, especially in this population. So, if healthcare practitioners don't learn about their patients' cultural beliefs and practices, then developing a trusting relationship with your patients and creating successful discharge plans are all for naught. You should be aware of the patient's entire situation, not just the clinical, not just the emotional or psychological, but their cultural situation as well. Their cultural needs, their cultural background, what's important, what's not important, how do they identify? Utilize one of those tools to be able to do a good culturally competent assessment of your patients. And last but not least, certainly not least, be aware of your implicit biases and do the work to ensure that you minimize the impact of your implicit biases on your patient interventions. Now, there are several different ways that you can do the work on your implicit biases. One of the ones that I've found to be very helpful is put out by Harvard University, and it's called the IAT implicit assessment testing. If you just look up Harvard IAT, you can get to it. It's a series of different kind of quizzes that help you identify where your biases lie and actually gives you pretty decent reports on, this is where your implicit biases are skewing you towards. And here's some ideas of where you should be working on to resolve those. And there's probably a set of like 30 or 40 different tests looking at gender, various and sundry ethnicity biases. Anything you can think of is in there. So take some time, work through those tests and figure out where your biases lie. And then you can start doing the work to mitigate those biases, or at least be aware of them, so that when you're working with a patient or a family that identifies as any one of these groups, you're aware that your brain's going to reroute you someplace else, and that you should be more thoughtful, more cognizant, and more understanding of where you are in working with that population, so that you can give better culturally competent care. Those are all my references. That's a post test that I use when I do this for other people's. And I know I'm early, but it gives us opportunity to chit chat and have questions from the other session and this session as well. So open up the floodgates and let's chat.
Okay, excellent, Colleen. What a wealth of information. It just kept coming. Fantastic. So I'll start with the question, but really those of you in the audience, you can add questions or raise your hand as we go through these. So my first question is, based on your experience and thinking about both lectures, and a lot on the readmission, which is very practical information you provided, that what is your advice for case managers today? Because particularly in New England, I'm sure throughout the country, the challenges we're faced with, and how do you apply the readmission information that you provided? So the challenges we face here: increased patient volume, low staffing levels, throughput is a constant issue because we're in a challenge, the number of hospital beds in our areas, and the financial challenges. And that, from, my last job, the case managers, really all day long are just, they're on the Maslow hierarchy of needs. A lot of times they're at food and water. And so how do they take that great information you provided? And I know that all case managers have a passion to, to work with and to be successful with readmission avoidance.
So what you're experiencing in New England, we're also experiencing in Chicago. Our ED is overflowing. My patient census has been 98 to 102% for the last 2 weeks. And then we had a little bit of a break over the holiday season. But before that, it was a full year of that. So much so that we had to create a new surge plan to identify it, opportunities and things like that. And our surge plan is in place, but we can't actually activate it because we're waiting on other things going on. I mean, when you've got avoidable days coming from patients and families not making decisions on the next level of care, to 4-day delays in insurance companies providing prior authorization for the next level of care, and the patient can't go anywhere without that, you're kind of stuck. So that's the whole throughput thing. I just went to a conference last week on patient flow and patient throughput. Some really, really great projects out there, but we're all in the same boat. We are all seeing this huge influx of patients. Before I started at UI Health, they said pre-COVID, their occupancy rate fluctuated between 80 and 85% on an average. And now we cannot get out of the 90s to save our lives, even even over the holiday time, where you would think that people are like, I'm not going to the hospital, but we stayed in the mid 90s in times where pre-COVID, it would be in the 60s or 70s. So we have experienced a shift, a monumental shift in people seeking healthcare services, right? So we've got to do the job of moving them along and moving them along. So throughput, I mean, I could go on for days on throughput. I've got a 12-page throughput plan that I'm in charge of for some strange reason. But
That's the next time we invite you back for.
no, I don't ever want to talk about that.
You don't. Okay.
Oh no, just I'm teasing. It's just like it takes up my entire world right now. But it really is a case of from the emergency room, how many of those patients could or should be shifted to their PCPs, and how many are using the emergency room for PCP services? How many are not connected out in the community? And how do we get them connected in the community? How do we increase that trust? How do we increase the capacity for community care versus seeking out the emergency room? How do we educate our patients and get them more engaged and more activated, that they're not going to wait until their toe is about to fall off before coming to the emergency room, but rather when it's been read for a couple of days, maybe make an appointment, right? So it really, the whole throughput thing feeds into the entire thing about patient engagement and patient activation. If you have an activated patient, even at that level 2 or level 3, they're a little more cognizant about what's going on with their health. And to do that, that is a huge culture shift for a lot of patients who, healthcare happens to me. My dad is exactly that. My dad is 80 years old, lives up in Green Bay. Thankfully, no medical issues, does not take a pill ever. But healthcare happens to him. Healthcare happens to him in the form of his daughter calling him up going, it's time for you to go to the doctor and do this. It's time for you to do that. He had a colonoscopy when he was 50. He said he's fine. He's never doing it again, even though his father died of colon cancer.
Right. So Karen Zander said everything case managers learn, they learn from their mother or father. She actually wrote an article on it. Yeah.
You're learning because you're trying to manage them. And I mean, I've got my dad, my mom, passed away from Parkinson's a couple of years ago. My youngest son was diagnosed with Hashimoto's thyroiditis when he was 8 years old, and a whole bunch of other medications. It's just been a full-time job keeping him alive. Thankfully, he's 22 now, and he's like, yes, I'm done. He's in great condition now. But you learn as you grow, and don't discount those personal experiences for that impact that they can have on your actual practice, because people will reach out to you because you're a healthcare provider, and they always want to know, what can I do about this and how can I figure that out? So, take those experiences and learn from them, but also seek out other the patient flow conference, perfect example. We've got a discharge lounge at UI Health. We have a very narrow set of criteria for our discharge lounge. So therefore, our discharge lounge only serves about 20 patients a day. Sarasota Medical Center in Florida and Brookdale Health System in Brooklyn, New York, are seeing anywhere from 70 to 100 patients in their discharge lounge every day. And their average length of stay in their discharge lounge ranges from 20 minutes to an hour. And their criteria is much wider, and they've got bigger capacity in that discharge lounge. So seriously, if you want to fix throughput, if you can take that concept of, if you build it, they will come. Right. And if you set it up so that even your patients going to a skilled nursing facility can be transitioned down to the discharge lounge, and the ambulance can pick them up from there, which is what Sarasota did, you're improving your throughput. So looking at what other places that are more successful are doing, instead of just trying to recreate the wheel and doing the same thing over and over again, which is and expecting a different outcome, not going to work, right? but opening up your mind and seeking out those other practices, doing the research out there, Google in there, better throughput, stuff. I've been able to bring back several different things from a whole bunch of different hospitals that we are now actively looking at implementing because it made sense, because we've got the outcomes from other facilities. The ROI for it makes sense. Adding 2 people in a non-clinical role to manage X, Y, and Z takes that off of the nurses and the social workers, making them more accessible to do more throughput.
Right. Yeah. So, I mean, those are great answers.
You got
And
me talking about throughput. What the hell?
no, just save it though. Okay. So, but I think that hospitals, we've become better with the discharge lounge. Like the discharge lounge just never seemed to make it. But recently, maybe it's the urgency, maybe it's our experiences. But the ones that I've been involved with, that they're so much more successful. So that's a great thing.
There's a really great program that Upstate Medical Center in Albany, New York put in place. I heard about it a couple of years ago, and I finally got a unit at my hospital to start implementing it and piloting it. It's called the 24-hour discharge process. So the day before the discharge, all the discharge tasks are split up between all 3 shifts of nurses, so that day shift nurse who's discharging that patient doesn't have all this stuff to do. Yeah. So it's all delineated. And by the time that discharge order is written in the morning, the patient is tied up in a bow, ready to go out. And they've seen their discharges by noon, which impacts throughput, skyrocket to almost 60% of their discharges. What a concept.
Yeah, fantastic. So there is a question in the chat, just a little bit ago. And the question is, what's the best way to know if a patient can read?
Teach back, actually. There is on AHRQ, health literacy. If you go into their health literacy world, there is, they call health literacy the newest vital sign, NVS. And that project uses food labels to test for health literacy. Yes. So you print out a food label and you go over the food label with the patient. So, or a medication label or whatever. And you explain it to them and you're pointing out things, and then you ask them to teach it back to you. So there's teach back tools on AHRQ. There's the NVS newest vital sign out on AHRQ. AHRQ has got probably the biggest plethora of health literacy. Thank you for the implicit association test. I appreciate that. But AHRQ has got such great resources for health literacy, and so does the Institute for Healthcare Improvement as well.
So the participant that asked that question, does that answer your question? If not, why don't you just please put more information in the Q&A. And then we did get one other reference. Thank you, Anna. That's in the chat.
Yes, that's the IAT, the implicit association testing. Thank you, Anna.
Oh, all sharing. Wonderful. So in my experience with readmission avoidance, like one of my final conclusions, and what do you think about a critical barrier to to trying to overcome readmission is loneliness?
I would definitely say that has an impact, especially with our older population who may be very, very what's the word I'm looking for here? Senior moment. No, isolated.
Yes.
Yeah.
Yeah. And they're not always as open to solutions.
Right. And
help them overcome the loneliness.
Especially. Yeah. And if you can get them to their PCP, and their PCP can get them hooked up with support groups or senior groups in the area, things like that, have a ready list of resources at the hospital level, especially, say, hey, you know what, this place has a senior lunch every Monday and Wednesday. you can go get a good hot meal and hang out with people.
Yeah, I think that's a great solution. So in answer to the question that I had about, how do case managers today facing all the stresses that they have, take on readmission avoidance if they don't already have a program
Mhm.
in their institution. And I thought, if we look at all the information that you provide, and then either an individual case manager or a case manager department, just pick maybe one
Mhm.
one of the
Just
programs,
start with one. You're not going to
start
solve the
with
whole
one,
problem overnight,
right?
but
And then the
understand your population too, right?
exactly.
Because it's not a one size fits all kind of a thing. Maybe your problem with readmissions is linked up with medication
Mm,
adherence or medication reconciliation. Then you got to get pharmacy involved. And there's some really great programs going on out there with pharmacy. Maybe it's I didn't make my doctor's appointment. Maybe it's I didn't go to my doctor's appointment. When we were making the physician appointments, we saw that 70% of our patients did not go to those appointments. So why not? And how do we fix that? Um, Maybe you've got patients who don't understand that they have a chronic condition that needs to be managed and they keep coming back to the hospital waiting for somebody to cure them. I cannot tell you how many times I've asked a CHF patient, what brought you back here? And I've been told, well, you didn't cure me.
mm,
And nobody has explained that this is now a lifelong kind of a concept for you. Um, One of the things that we did at West Suburban was we put together our health literacy lab. And it's an interdisciplinary, multidisciplinary intervention where it kind of looks like, circuit training for chronic condition management. And you meet with a master's prepared nurse, you meet with a pharmacist, you meet with respiratory, physical therapy. There's a demo table for a whole bunch of different pieces of DME so that you're not afraid of the new stuff coming in and you get your kind of hands on before you get home. And then meet with social work and finalize your discharge plan. And we had such great engagement from our patients. People, we use the health confidence scoring tool, right?
yeah.
And we did it before they went in there. And we said, all right, how confident do you feel about taking care of yourself when you leave here? And some people get a little cocky and go 10. And you're like, 10, you've been here 3 times in the last 2 months. Come on now. Um, and then they go through it and then they're like, oh my God, can I rescore that? No, you can't rescore it, but you can add a +1 if you feel that you're better now. But it was really impressive because, like I said, when we first started using the tool to interview our readmitted patients without any kind of an intervention, we were at like a 5.2. And we were like, we got to do something here. And when we started with the literacy lab, we increased our patient's health confidence score to an 8.4 overall,
Oh,
and reduced our readmission rate for that population by 52%.
so is that written up?
Oh yeah, that's what I won the CMSA Foundation Practice Improvement Award for.
Is that on your references at the end of your when
Actually, that's going to be my next book is how to put together a health literacy lab, and I'm working on it. It'll be probably out next year or so. But there is an article in Professional Case Management Journal about it, and it pretty much lays out the how to. And if anybody wants the how to, give me a call. Happy to
okay,
help.
so to get the article, because do you remember the name? Can we Google it?
The article is health simulation and readmission reduction, and it's in Professional Case Management Journal.
Okay. When you said you love your work, we believe you now. Than before.
Well,
So then, yeah,
and
go
then
ahead.
and then look at readmissions from the other side too. My original thesis work for my master's and my doctorate that one article that I read from you years and years and years ago inspired was um, taking Project Red, Dr. Brian Jack, who, personal hero. Thank you so much, Maureen, for introducing me to him and making like top 3 people I've ever wanted to meet in my life were Dr. Brian Jack, Dr. Gene Watson, and Harrison Ford. And I got 2 out of the 3 right now. So if anybody knows how to get to Harrison Ford, please let me know, because that would just like be my trifecta of happy right there. So I took Project Red, and Project Red's like a single discharge phone call 48 hours afterwards, blah, blah, blah. It's got a whole bunch of other
It was
great.
done down the street from us in
Yeah.
Boston. It's a
Mhm.
university. Yeah.
Yep. So Project Red is like the grandfather of all great, post-acute transition stuff.
Mhm.
And I'm very, very happy that, they've included me in their team now, which is kind of cool and a really big honor. But I took that program and I created a follow-up program for 30 days. I mean, at least once a week, touch points with the patient on the phone, sometimes twice a week, sometimes daily if that's what the patient needed, but literally micromanaging a patient from the time that they're discharged through the 31st day. And we did it as a pilot at the hospital that I was working at. The company that I was working for at the time was a national healthcare company, rolled it out to all 38 of their hospitals. And I just recently went back in and I took a look at their data. In 58% of their hospitals, they have a zero readmission rate for AMI, CHF, and COPD using that program because it engages patients and it helps get them activated. You are working with them. You've got a great relationship with them. It's all about relationship building, building that trust, and giving them that education in ways to improve their activation in steps. You can't just throw it all at them and expect them to be super activated patient the following day.
Right.
This
and
is
so
this is
that
a
intervention
process.
too
Mhm.
overcomes the loneliness program
Exactly.
I've been involved in. Like I made, when I was through working on some of the projects, I thought, so how many patients feel like they belong? How many patients were really cared for,
Mhm.
in their life? Because there's some people that never have felt like they're connected to anybody. And
Yep.
that could be the reason behind all the readmission that you're doing the work, although it is, positive and makes a difference, it may not be touching on that. So this has been great, Colleen. I think we did a podcast and oh wait, I have something to share.
Share with attendees about Project Red. Go for it, Maureen.
Yeah.
Okay.
We're just in chit chat time now.
Yeah, and let me just finish. Just let me finish real
Go
quick.
ahead.
So what
You
I was going to
finish, yeah.
say is that all the work that Colleen's talked about, it shows that the readmission strategies that have been developed, that they really do work, and you can get to a zero readmission rate. Colleen saw it. I've done it. It can happen. And I'm sure a lot of you in the audience have done it too. So Maureen, go to it, hon.
Okay, so I wanted to share that there is some free webinars out there about Project Red. Let me see if I can share my screen. I tried to break this down a little bit. It's through we've had Irving Stackpole speak to us several times, and we've worked with him. But there's one upcoming on February 21st. These are free. And Colleen is going to be the speaker on it.
I'm just saying, is that Colleen?
That
It
is
is.
me. I have
It
recently
is.
been invited to join the Project Red team.
Fantastic.
I am, you have no idea. They called me up and they asked me, and I'm just like, what?
Yeah. So they have a series of free webinars. I think it's a once a month. Well, it's 4-part. It said this is the second of the 4 parts. I will put this in your in the chat, and I'll include it when I send you out your certificate also. But I just wanted to recognize Colleen for all the work she's done, because she just doesn't do CMSA in her own work. She is out there in the community in sharing. And this is about on international transitions of care, so it should be very, very interesting. Do you have anything else you want to say about that, Colleen?
Well, I mean, the Project Red principles are literally AHRQ recognizes Project Red as like the best practice in transitions of care. And transitions of care is really where readmissions, can be halted, can be, we can stop readmissions by improving our transitions of care, the education that we're giving our patients, the support that we're giving our patients, the mindset of, roll the patient out the door, bye, see you later, hopefully not, doesn't work. We've got to realize that, we as a healthcare continuum have to be with that patient literally almost every step of the way. Supporting them, being there for them. We might not need to call them every day, but we need to be available to them every day. So if you've got, the ability to put a program for follow through into your facilities and staff it with a couple of people who are able to take incoming phone calls from patients who might not be able to get a hold of their PCP or don't have a good relationship with their PCP, and are able to be that intermediary between the hospital, the patient, and the PCP, and help build that better relationship, it goes a long way.
Yeah, absolutely.